Hello everyone, this is Dr. Davis again. So we have now moved on to our second exam. So this is Module 3. This is the first part of the exam, and then there'll be a second video with Module number 4. These are our learning objectives for this section. So we're going to talk about physiological changes that happen in the postpartum period, identify critical elements of our assessment, safe and effective nursing care, and discharge teaching. All right, so we're going to talk about the normal postpartum period. So this is that period after pregnancy and delivery. It lasts about 6 weeks. It takes the body about 6 weeks to return to a non-pregnant state. Everything has to switch from being pregnant for 10 months to now I have to immediately switch into a new state, which is that postpartum period. So really, the care during this time is focused on wellness, family integrity, a ton of teaching. Okay, so teaching is going to be initiated right on at the beginning because you're going to start teaching about how for the patient to take care of themselves. If I had a C-section, I need to be teaching about incisions. If I had any kind of tears or episiotomies or any repair work, then all of that stuff has to be taught to the patient. And then we're going to talk a lot about the emotional needs of mom, baby, and family. So client and family teaching is a huge subject on NCLEX. So you have to remember the first step in a teaching process is determine your patient's level of knowledge and identify their readiness to learn. Okay, so we're trying to teach them in the immediate period right after they delivered their baby. They're not going to remember a word you say. All right. But once that initial kind of 4 or 5 hours are starting to be over with, then we can really start teaching a lot with our patients. So we're going to be teaching about change and bleeding, which is Lochia, perineum care, breastfeeding, how to take care of a baby. Some people have never changed a diaper before. All of these things are going to need to be taught to our patients. All right, so some of the first things that we do, other than dry baby off, that's always the first thing that we do, get baby skin to skin with mom. We are going to make sure that baby is banded um, right there in the delivery room with mom present. Um, this is really important because we're making sure that this is the correct baby that belongs to this mom. So we've all, or hopefully you've heard over the last few years, not as much anymore as we did, but there was a big case in Jacksonville where the baby was stolen. She just recently was unified with her family, and she was over the age of 18. So this person that had taken her from the hospital in Jacksonville raised her. So we're making sure that bands are in place. This way we don't end up with a baby switching problem. Okay, so mom is going to be banded, whomever her significant other will be banded, and then baby gets 2 bands. They also get what is usually it's a hugs tag. There are other dealers of these security devices for babies, but the big one is called a hugs band. On this baby in the picture, it's actually attached to the umbilical cord. The ones that I worked with actually went on a foot, so you just put it around the ankle. and the little hugs tag, you kind of clicked it, and it had to be touching the skin in order for it to be engaged. That way, if for some reason the baby kicked it off, then the alarms will go off and we have to go back and put that back on baby and tighten it up. We're going to do erythromycin ointment and vitamin K. So usually in the olden days, I will say, we would go ahead and do that right away. Now they're trying to delay that for as long as possible. A hepatitis B shot is usually done prior to baby leaving the hospital. Some of your pediatricians will ask that you not start your hepatitis B shot in the hospital, but to start them in your office. And that's just my pediatrician would say that she liked to be the one that did that because it was easier to keep up with how many doses of medications the baby has received. But many people will go ahead and get that hepatitis B shot before they go home. Footprints are for sure done. Footprints become very much like fingerprints for adults. They're the only thing that's going to have creases and other things in it. Baby won't have really any fingerprints yet. Those are yet to really form. So footprints for sure will be done, and mom's fingerprint, and all that goes on one sheet of paper, as well as who received the ID bands and the numbers on the ID bands. All of those things go together on those security forms. Okay, so these are things that we are going to assess in the postpartum period. So still going to do vital signs. We're going to look at fundal height. Lochia, how are they voiding? What's their perineum look like? Bowel sounds. We're going to observe for thrombophlebitis. And then we want to remember that symptoms of postpartum infection are the same as if you were had a regular kind of infection, right? My temp's going to be elevated. I might have tachycardia. I might have pain. So those are all good things to remember. Okay, assessing our vital signs, our heart rate and temperature. So why is this important? So you may see some bradycardia, and by bradycardia, in those first 6 to 10 days, what I mean when I say bradycardia is it's a lower heart rate than what patient had before delivery, because now I don't have that extra blood volume circulating, so that heart rate should kind of come back down into a normal range. And you may see even a lower bradycardia, right, if we're doing pain medications, if patient's sleeping, all those other kind of things, okay? Um, Tachycardia, we are going to be concerned about, all right? So tachycardia could mean that I'm having some sort of blood loss, my temperature is increased, there's an infection, I'm having pain. So those are things that we want to look for there, okay? As far as temperature, the first 10 days postpartum, um, we're going to watch for a temp greater than 100.4. If we have 2 of those, then we may be at risk for some kind of infection, and puerperal means uterine infection. It's just not a word we use very much. It's not easy to say, so I'm just going to add that in there for you. All right, so continuing our vital signs is respiratory rate. So our respiration should still stay in that normal range of 12 to 20. If I see any variations in that, that may be from a pain response, it may be an anxiety or a fear response, it may be from pushing and exertion. So all those things we want to watch. Now, if we have a patient who's telling you they have a sudden shortness of breath, chest pain, restlessness. This could be a pulmonary emboli. Okay, this can happen sometimes with very devastating results. So we definitely want to make sure that we are talking to our patients about this and telling them what signs and symptoms they need to seek help from a physician. All right, so our vital signs and our blood pressure. So many times there's a increase in blood pressure right after delivery of both the systolic and diastolic, but usually over the next few days that blood pressure will return to baseline. Now, if mom already had an increased baseline, having an increased blood pressure right after delivery, you're going to have to really pay attention to what's going on, okay? We can end up with a mom that's having a lot of other issues as well. If the rise in blood pressure continues and does not go back down, then we are going to see about having the provider prescribe something, but we're also going to do a bunch of labs and we're going to assess the patient for any headaches or visual changes, any epigastric pain. So once we get to our high risk stuff, we'll talk a bit more about preeclampsia, but you can become preeclamptic both before delivery and after delivery. Some of the really sick ladies that I have taken care of did not become preeclamptic until after delivery. So that's something that we want to really pay attention to for sure. I've had several people come back later with preeclampsia and full-blown eclampsia where they were seizing on the way back into the hospital. So it can be very, very bad. Orthostatic hypertension may also happen in that first 48-hour period. So why do we think orthostatic hypertension might happen after delivery? So think about all of the things that have just happened in my delivery, right? I had all this extra blood circulating, fluid volume circulating. I've now pushed this baby out or had a C-section, either one. The placenta is out, the extra fluid is gone, I've probably bled. All these things, maybe I had some anesthesia of some sort. All these pile on top of each other, and then you can end up with somebody that's going to faint the first time you get them up. Okay, so these are all things that we need to think about when we are assessing our patient. So involution. So involution is where that uterus that was stretched out to carry the baby, the fluid, the placenta, all that good stuff, is now got to return to its normal state or size after delivery. Okay, so it takes up to 6 weeks for that uterus to return to normal size. Usually the uterus or that fundus will decrease a centimeter a day. So in class, I will show you, if not, then during our simulation, sorry, I totally forgot the word. I will show you exactly how this works and how we measure it. So that's something that we will discuss, okay? What we need to understand for nurses, what the important part of this is, as long as the uterus is making those changes, it's getting smaller, it's not staying boggy, which we'll talk about in just a sec, then there's really no need for any kind of intervention. Okay, so we are going to palpate the fundus. Remember, the fundus is the top of the uterus. We need to know where is it located and how does it feel. So our next slide will discuss that a little bit more. So I'll wait to talk about that one. But a boggy uterus, so that's when I'm getting ready to assess um, mom's uterus, and it should be at, a couple cms below her belly button, her umbilicus. Um, but instead, it's much higher. When I start to rub it, it's not hard like a grapefruit. It's more squishy. That's what boggy means. So typically, this has something to do with mom's been in bed for a while, and I haven't got up and voided recently. That's usually your biggest culprit. So we'll have our patients get up and void before we do this assessment for sure, and then kind of go from there. If it stays boggy after that, then we have to do some other things. Okay, so talking about assessing our uterus. So in this picture, you see that the nurse has her left hand there on the symphysis pubis bone, kind of to support the uterus. And the other hand then is trying to see how far away from the umbilicus is that fundus. So that's kind of our measuring point is that umbilicus. All right. So when I say that it should be um, that uterus should decrease by a cm every single day, we'll use our fingers as that measure. So I'm going to put my hands and kind of feel where is that fundus on that uterus. If it feels a little boggy, I'm just going to massage a little bit. Um, and then kind of measure how far below that umbilicus is that fundus. Typically, you will see it charted as U minus 2, meaning umbilicus minus 2, so 2 fingers or 2 cms below that umbilicus. Um, why is it important to keep that second hand down there on that symphysis pubis? Because we don't want to push things out the wrong way. So now you have this organ that's larger than it's supposed to be. If I get very vigorous with it, it is possible that that uterus can turn inside out and come out the patient's vagina. So yeah, that's not good. We don't want to do that. So typically we have mom void first and then have her lay down on and do her assessment and assess that uterus at the same time. So what is uterine atony and why is it important? So it is important because it means that um, just looking at the word, A is none and tone is has to do with the musculature, so there's no tone to that uterus. Instead of when I massage that fundus, that uterus should kind of cramp down, become about grapefruit softball kind of size. If we're not doing that, then that allows those places inside that uterus to bleed. And uterine atony is really one of the biggest causes of postpartum hemorrhage. It can happen, usually it can happen with that in that first 24-hour period. So you may think you're really good, and then all of a sudden something else is happening. Um, so if that uterus is not contracting and putting pressure on those vessels to keep them um, from bleeding, that uterus is going to fill up with lots of blood and clots that can lead to a hemorrhage. So that is why we are assessing that fundal height and the tone of that uterus. As well, we are you can massage that uterus, but we also will then move towards doing some different kind of medications. Sometimes the first medication that we're going to give is Hemabate, and that's an IM dose. Typically, I give that right in the thigh. As it's a little bit larger, it's an ml, so that's usually quite a bit to put um, in a shoulder or in an arm. So Usually I inject that right into the thigh, or they may use some misoprostol, which is Cytotec. So these are all different kind of postpartum hemorrhage kind of medications that we will use. Okay, so postpartum hemorrhage is bleeding after birth, greater than 500 mLs after vaginal delivery or greater than 1,000 after a C-section. So there's some kind of significant blood loss. Um, this is the number one reason for maternal morbidity and death. That hematocrit and the hemoglobin, you'll see a decrease of greater than or equal to 10%. You'll see changes in mom's heart rate, blood pressure, her O2 sat. Um, there can be a primary postpartum hemorrhage, which is within that first 24 hours, or a secondary postpartum hemorrhage, which is after 24 hours. So this is why we are very diligent about educating mom, especially if mom is going home early for some reason. Maybe baby was very small and transferred to another facility, so mom wants to be discharged. So we really need to make sure that mom and the significant other is aware that if we're starting to have other issues, that they need to seek assistance from a physician. All right, so talking about postpartum hemorrhage, what things can cause postpartum hemorrhage? So these are called the 4 T's. So tissue, meaning maybe part of the placenta is retained. So when mom delivers baby and placenta, the physician should be taking a look at that placenta to make sure all the pieces are intact. We'll talk about these a little bit in class, and I'll show you what I'm talking about. But the way the placenta is formed, it has little hunks of tissue all over, and those little pieces can stay retained in that in mom's body. It's still putting out some hormones, so the body doesn't know what it's supposed to be doing. So it thinks it's delivered, but I still have some of these hormones being released due to this piece of placenta. So I'm still thinking maybe we're still pregnant, so it can cause lots of problems. Our tone is our uterus. Is the uterus staying floppy or boggy? Or is it able to become nice and firm when it's massaged? Was there a traumatic delivery? So maybe as baby was delivering, we end up with a shoulder dystocia, which we'll talk about later. Or maybe baby wasn't tolerating labor so well, so they put a vacuum on baby's head. Those kind of things can cause some internal trauma to mom and can cause some increased bleeding. And then lastly, thrombin. So this has to do with any coagulation disorders. People that have frequent miscarriages um, sometimes will be put on heparin or during the pregnancy because they have found that some of the biggest issues with people having multiple miscarriages is there's a some sort of a clotting disorder. So those people are going to be at higher risk for bleeding. Okay, so hopefully this little pic will help with the understanding of fundal height and the way the uterus kind of starts to decrease as um, the days go on. Now, it does get a little confusing. So right immediately after delivery, this uterus is going to be very small and um, cramped up. So it's going to be very firm. It'll be contracted. So it will be softball size about then, if not a little bit smaller. It even sometimes will be real hard to almost feel it above that symphysis pubis. But then as that 4-hour period of recovery gets over with, then it's going to relax a little bit, which is okay as long as we're not having lots of bleeding. Okay. So if you look in this picture, you can see the patient's umbilicus is right there at day 1, day 2, and then day 3 is where you're really going to find it most of the time. And that's about 2 cms. It may be a little bit more in this picture, but if you were measuring on her belly, that's basically you're measuring 2-finger width below that umbilicus is where we're trying to find that uterus. So that is kind of your standard that you will find for postpartum nurses. That's typically what you'll see charted. So we're looking for, is that firm or is it boggy? So if it's boggy, it's possible that mom has been in the bed for a while. Say it's your day shift and you're coming in at the beginning of the shift. Maybe she's been asleep for a few hours and hasn't got up and voided. So that bladder filling up, just as it gets in the way for delivery purposes, it also can get in the way of that uterus staying clamped down. So if mom hasn't got up in a few hours and voided, usually the first thing you want to do when you go in to assess her is just ask her to get up and go to the bathroom. Now, you do have to understand that when you are laying down, especially after you have a baby, if it's been a couple of hours, then that blood is going to collect. It will clot up some. And when I get up and go to the restroom, it's going to come out. It's called gravity, right? So that, that bleeding is going to come out. It typically scares mom quite a bit because, things have been good. I really haven't had a ton of bleeding. I get up and go sit on the toilet, and now I'm having, a huge clot come out. So very often we will get phone calls, or calls to the room that they've gotten up and they have a large clot. That's okay as long as you've been laying in the bed for a while. Now, if you've been up and down, up and down, up and down, you're constantly moving, you go and sit down on the toilet, you're passing clots, different story. Okay. So typically I'd go ahead and have mom get up, go void, then I will assess the uterus. Then we can massage that fundus some. Then we can move to giving oxytocin if we need to. If we are using oxytocin and we've massaged that fundus and it's not returning to that contracted state, then I'm going to be concerned about, are we moving into a postpartum hemorrhage kind of a situation? So at that point, we need to call a physician. But make sure anytime you call a physician, we have a new set of vital signs and you've completed your assessment before you give them a call. Now, by saying that, what I mean is if this patient is bleeding, actively bleeding with clots coming out, as you're massaging the fundus, someone else can be calling that physician while you continue your assessment. Okay. Or someone else can come in and continue to do the assessment, listening to heart and lungs, make sure we don't have anything funky going on there, while you go call the physician. All right. So by no means am I saying in the middle of an emergency kind of a situation, do I complete a full assessment before I go and call my physician? No, not necessarily. I may have someone else call the doc and tell them I need you to come on or head towards the hospital. Maybe they're already in the hospital somewhere. Can you come up to this room? We have a patient with some extra bleeding. So those are kind of the things that we're going to do for postpartum bleeding. All right, so this slide talks a lot about the uterus again. Okay, so discusses a lot of the things that I just talked about. I won't reiterate all of this, but we will talk about it a little bit more in class. And I do have a good mannequin that we can all palpate that um, fundus with. So hopefully we can sneak over to the sim lab and feel that at least before we get too many of you in clinical. So remember when I discussed about a distended bladder, if you look towards the bottom here, a uterus that's shifted to the side may indicate a distended bladder. So if I go to assess that bladder, that uterus, and it is not in the middle and it's slightly to one side or the other, then I'm going to be concerned about if um, this patient has a distended bladder. Okay, so that's why I said it's just easier when you first come on to have mom get up and void or find out how long it's been since she has voided, um, because this is an indication that she has a lot of bleeding going on. So we need to take away the easy things first, right? We need to deduce what is happening. So we're going to start with the easy thing was have her go void and then reassess it. If I reassess it after she voids and that uterus is still in the wrong place, it's displaced, or it's still boggy, then yes, I'm going to contact my physician. Okay. Um, so if mom has voided or is unable to void, we are at that point when we're assessing our uterus that we will have to put a catheter back in. It has been my experience, though, if you bring a catheter into the room, people can void pretty quickly for you because most of the time they don't want that catheter placed, right? So it's magical like that. As nurses, you will find that there are things that are magical like that. Sometimes it's people who say they can't drink fluids because they're nauseated, but you bring in IV to get an IV started and they're super happy to start drinking. Okay, so sometimes you have to kind of just do that and wave that around in the room a little bit, and they decide that they can do a little bit more than what they thought. Okay, so lochia. What does lochia mean? So lochia is the bleeding, the discharge that you will see coming from the vagina after the patient delivers. Okay, so typically your C-section moms, you'll see a little bit of a lochia serosa, more color, which is a pinkish or a almost a diluted looking rubra red discharge. That's because after baby's delivered, placenta's out, the physician will clean out that uterus with some saline, so you'll have a lot of that that comes back out. Typically, while they're still in the C-section room and comfortable, some discharge um, or uterine massage will be done, and um, to make sure that all those clots and everything are out. So you may not see as much bleeding right away from a patient that's a C-section, um, but definitely a patient that delivers vaginally, you're going to see lots of lochia, which will be described as rubra. So that is bright red bleeding. Typically that lasts 1 to 3 days. Serosa then becomes pink to brownish, and then alba is kind of a whitish, yellowish discharge. Um, and all this can last up to 6 weeks postpartum. Now, a fun fact to throw in there is that ladies, you can restart your period in that 6-week time period if your body is real regular like that. So it's possible that you will start bleeding again. Typically, we ask that if you go from Lochia alba back to Lochia rubra, which means I go from a white discharge to a red discharge, I need to let that physician know. Most of the time it's your period, but you still need to make sure that you're speaking with your physician, because anytime you've progressed from one stage to another and then you start going backwards, we can be very concerned about that. Okay. So how do I document my lochia? So I'm going to say it's either scant, small, moderate, heavy clots. So those are things that I'm going to be looking at. So another thing you do have to think about when we look at these pads over here, um, this last one is a heavily saturated pad. If I've only had that on for 1 hour, yes, that is considered heavy bleeding. If I've had that pad on for 4 hours, that's really not heavy bleeding. Okay. So you need to be very conscious of people, especially if you're watching someone for heavy bleeding. We usually ask them to either do a pad count or leave their pads in the put down a big, we always called them green pads, but they might be blue pads, the under pads that you put under your patient that help soak up fluids. Put one of those down in the bathroom and ask them to line up the pads on there, doing a pad count. Okay, so these are things that we're looking at. So for our normal patient that delivered, you should be charting moderate rubra. That is normal to have a decent bit of bleeding. And it should be red. Okay, so if we have someone that we're concerned about may be bleeding too heavily, we're going to be looking at quantifying that blood loss. So how's the best way to do that? Well, we're going to weigh pads. We can weigh sheets. You can weigh anything that's soaked with fluid. 1 gram of weight equals a ml of fluid. So how do I do this? Well, you weigh the dry ones first, right? I find some that are clean. I weigh them. I get the total. So maybe my total is 10, right? I weigh the same thing that is soaked, and maybe my total is 40. So I'm going to subtract 10 because we knew 10 was already how much the pad weighed. So you have 30 mLs of fluid loss. And remember, we said in the other slide that greater than 500 or greater than 1,000, depending on how you deliver, is too much. So this is how we kind of quantify blood loss when we have someone that we're taking care of. So things that I want to tell my patient about lochia. All right, so typically it has a musty kind of odor. I mean, it does smell like bleeding. If the patient starts to have a foul odor, then that's a suggestion of an infection, and we really need to get with our doctor. Anytime that your bleeding is heavier in the morning, just want to remind them that if they're laying in the bed sleeping, that can pull and collect, and then when they get up in the morning, they're going to have a kind of a gush of some bleeding, but then to watch your bleeding after that. You may have increased lochia when if you're up moving around a lot, or if you're breastfeeding. Breastfeeding releases those same oxytocin kind of chemicals in your body, and that will make that uterus cramp. So you may have some increased bleeding with that as well. Okay, something else important that we need to talk about are urinary tract infections with our patients. Why is this important? Why would they have a UTI after a delivery? What do we think? So many times, or well, not many times. So I've had a delivery, I've got a lot of stuff going on in that area, right? So all of the things in this area, including urethra, bladder, everything can kind of be affected by delivery or being pregnant. So these are things that we need to talk about with our patients. If I had an epidural, I probably had a catheter in. If I had a C-section, I had a catheter in. So what do we know about catheters? Catheters can cause infection. So these are things we need to let them know about. So any of those normal kind of urinary frequency, pain when they're voiding. Now you have to really be specific with pain when you're voiding, all right? Because you may have a mom that has pain when she voids because she had a episiotomy, so it's going to burn. But we're looking for a different area, right? We're talking about when you start voiding, do you have any specific pain in that urethra area? Okay, and you do sometimes have to discuss with your patient that there are different holes in the female's anatomy. Not everybody understands that there is a specific hole where you void. There's one, you have your vagina and then you have your rectum. Okay, so you may have to get very specific with them. So these are all things that we're going to look at there. Okay, hemorrhoids. So, teaching for our mom and why in heaven's name would she have hemorrhoids? Okay, so we have increased blood flow to the bottom half of her body. She's carrying extra weight, right, from baby and uterus and placenta. So I may have hemorrhoids before I deliver, but I also may have them after I deliver. Why would I might have them after I deliver? Well, if I pushed for a good little bit of time, it's possible that a hemorrhoid has developed from pushing. Um, because as you use those same muscles that you do to have a bowel movement to push baby out, same muscles, right? So you're straining, all those things come together, and you may end up with um, a hemorrhoid. So teaching to mom, um, we want to make sure that mom is sitting on somewhere flat and hard. They do make the hemorrhoid pillows. Um, that's really important. If they're just sitting though, like on a soft surface, sometimes the um, your buttocks can separate some and there's a decreased flow, which is going to make that pain increase. So it may be better if she doesn't have to sit, if she's got some bad hemorrhoids, for her to lay on her side. That might be the best thing to do. We can do some ice packs. We can do some anesthetic sprays or ointments, and witch hazel pads work really well, which are those Tux pads. Those are very helpful. All right, so when we talk about our hematological system, what happens during delivery and afterwards. So prior to um, delivery or when mom comes in labor, you're going to see an elevated WBC count. That is perfectly normal to see a 12,000 to 25,000 WBC count. It is part of the labor process. Um, so we can't really use that as a determining factor if this mom is infected or not. We have to look then at temperature, heart rate, all these of the other things that we look for when we're determining infection. So you may see an increase in blood clotting factors. So you may have a risk for thromboembolism and a pulmonary embolism, like we talked about before. And then our hematocrit should hopefully rise prior to and then after delivery. It doesn't always happen though. All right, when I'm assessing my perineum and talking about pain medications, So what I'm going to be looking for is, first of all, did this mom have some sort of repair done? Okay. Is mom having any kind of increased bleeding that isn't normal? Sometimes if there's a little tear or something that wasn't repaired, um, you can have some increased bleeding. So you might want to take a look at that. Typically, we ask mom, especially in the bed, because when you're sitting in the bed, that bed kind of cups around your body. So you may need to ask her to lay on her side and then use, a flashlight to look if it's very dark in the room. So we're looking for redness, any kind of edema. Is everything intact? Is it sewed up like it's supposed to be? Do we have stitches that are coming loose? We're looking for formation of hematomas. Typically, if we're having hematomas form, that is from a much more extensive repair. And we for sure need to grab a mirror and kind of teach mom what to be looking for, especially if she's going home after having an extensive repair. Extensive repair, I'm meaning she's had a 3rd or 4th degree tear or or episiotomy. Um, the 4th degree extends through to the rectum, so that's extensive tearing, right? And when we're having to repair all that area, it is possible that if you're repairing through to the rectum, that everything doesn't get back aligned up, everything's not closed up correctly, and you may end up with some different fistulas that have to be corrected. So those are things that we need to really be careful and teach our patient about, especially if they have extensive repairs done. Okay. Afterbirth pains are normal. Typically, they'll get better after about 3 days, but they will still have some cramping. If you're breastfeeding, you're going to experience some cramping with breastfeeding for a good little bit. That's just part of your body protecting itself. So we want to teach hygiene. So sometimes these ladies that have extensive repair work, or even just a 2nd degree repair, we need to make sure that we're telling them that they need to change their pad every time they go void, or every time they have a bowel movement. That pad needs to be changed. Okay. Some people are not aware. They think that they can wear a pad longer because it's not as filled up. And while that may be true during, say, a regular period or menstrual state, we are not there. We are in a postpartum period, and these need to be changed frequently, as we don't want anything that can cause infection in there. Okay. Definitely have to remember that they need to wipe front to back. Good hand washing is important, and then we're going to teach about ice packs, sitz baths, using the squeeze bottle, spray bottle, especially if mom has any kind of repair work done or any tears. That squeeze bottle is going to be super important. It's just a bottle with a squeeze lid that you fill up with water, and as you're voiding, you spray the water at the same time. Basically, all it's doing is diluting the urine, but you have to remember urine is very acidic. So if I put something that's acidic on a tear or a cut, it's going to do what? It's going to burn, right? So using that water, basically all it's doing is it's just diluting the urine so it doesn't burn. But many women will tell you that that bottle is a fabulous tool, okay? And then you can use some anesthetic spray or pad depending on whom your physician and midwife are. Pain medication. So usually we do ibuprofen for 24 hours or so. Typically we do 800 Q8 and pretty much give those. They are a PRN med, but I usually try to give those pretty much around the clock. It just helps with the cramping. It keeps your patient more comfortable, And then we are not worried so much about having to try to get them comfortable again. Remember, with acetaminophen, we can only do 4 grams in 24 hours. So anything that has acetaminophen in it, we're going to be concerned about how often they're taking that dosage. And then if mom is nursing or breastfeeding, it's important that she takes something. That's why we usually just go with the ibuprofen about an hour before they breastfeed, because they are going to cramp more at that state. All right, so discharge teaching. So these are going to be the focus of your discharge teaching. Now, the thing about postpartum is you cannot wait till the last minute like you could on a med surg unit to do the discharge teaching. You've got to start discharge teaching after delivery. Give them a couple hours um, before you really start hitting it hard, but you're going to have to do discharge teaching the entire time, okay? And you may have to repeat the same thing over and over again. So if you're not interested in really doing a lot of teaching, postpartum may not be the gig for you, okay? Because it is continual teaching, reinforcing of teaching. So we're going to talk again about good self-care, changing the pads, using that peri bottle. That's the spray bottle. Um, Resting when baby rests, drink lots of water, wash your hands, how to use the car seat, um, breastfeeding diet, engorgement, sore nipples, all those fun things that we need to discuss. If mom is not breastfeeding, we'll have to discuss formula, how to mix it, all kinds of stuff. Now, most places have a ready-made packet that mom can take home with her. That way, when she totally doesn't remember a word you said, she can go back to that packet and look it up. Um, so, but we still have to go through all this with them. All right, so signs of complications, things that we're going to either need to report to the physician or have the patient report to the physician. So heavy lochia, that's that saturating a pad in 1 hour or less. Um, Return of bright red heavy bleeding after it's become serosa or alba, or we're starting to have clots after they've already moved through those stages. Any kind of foul smelling lochia, increased temperature, pelvic or abdominal tenderness that has increased. So maybe it wasn't that tender, but now I'm very tender. Frequency, urgency, or burning on urination, breast tenderness, warm reddened area, chills and fever. All of those are kind of signs and symptoms of mastitis, and it does have to be treated. Blurry vision, severe headaches, epigastric pain are all signs of preeclampsia, so those are important to report. Pain in the back of their legs, swelling or redness can be a blood clot in their leg, where chest pain and difficulty breathing could be a pulmonary embolism. And then lastly, but also very important, is thoughts of harming infant or self, difficulty caring for self and infant, not sleeping, persistent feelings of depression and sadness. Those are all considered postpartum depression. Okay, there's a difference between postpartum depression and baby blues. So we will talk about that a little bit as well. Okay, so why is it important for us as nurses to worry about the significant other? All right. I changed this from saying dad to many times now we have significant others. That might be a sister, it might be a best friend, it may be um, you know, it may be baby daddy, it may not. It might be mom, it might be grandmom, it might be great grandmom, right? So it's our significant other. Who's going to be with mom to kind of help her, even if it's not helping her in a 24-hour a day kind of a thing. Maybe this person is just going to be checking in every day. or spending the night with them. However, that significant other person, we do want to check in and make sure that they're able to help. Do they know how to change a diaper? Do they know what things are important to report to the physician? Do I understand that if mom is having an issue with postpartum blues, at what point are we concerned about this becoming postpartum depression? Okay. Um, so this slide talks a lot about fathering role, um, but that's not realistic for a lot of our patients. I wish to say that it wasn't, but this just unfortunately is kind of the way things are heading, right? So all these things are very important. We do want to make sure that we are checking in with that significant other person, but also doing the teaching with both of them, because that significant other may be much more ready to understand and be teachable than mom at that point. Okay, guys, so this can be very confusing. Please don't get too deep into this, okay? The thing that you need to remember is if mom is Rh negative, then she has to receive RhoGAM at 28 weeks and then again after she delivers. If anything happens in that period when she's pregnant, I'm in a car accident, her physician's probably going to want to give her a dose of RhoGAM. Okay, so let me try to very simply explain what happens here. Okay, so remember way back in one of your sciences when we did those squares and we figured out what blood type was more prevalent, and if mom was O positive and or dad was O positive, mom was O negative, what are the odds of what the baby will end up being? So because O positive is much more common, it's considered a stronger trait. Typically, if dad is O positive, mom is O negative, baby will be O positive. Okay. So what does that mean? It means that the woman's body sees this O positive baby. It can be B positive, it can be A positive, it can be AB positive. It doesn't matter. If mom is negative and she has a positive baby inside of her, her body thinks that that's a foreign object and I need to fight it off. So that means what? Well, my body's going to try to reject it and get it out. Okay, this is the same immune response that you see when you get sick. Your body starts to fight off the infection to get rid of it, right? Same thing happens if mom is negative and baby is positive. Okay, now many times your physicians will they'll draw blood once baby is born and they'll get the blood type of baby. It's possible that baby might be negative and mom is negative, but we typically go ahead and treat them because it doesn't hurt to not treat them. All right, so when does this become a problem? So the first time the mom gets pregnant and she's Rh negative, it's not such a big deal if she's treated or not treated. Because remember, when you first are exposed to something, um, your body may not react to it as much, right? So maybe the first time I wasn't very sick, or my body didn't fight off that baby because the baby was um, positive. But the next time I get pregnant, my body has been exposed to that, and now I know to really fight it. So if we don't treat mom, then we end up with mom having a miscarriage because my body is fighting off this baby. All right, so this drug, RhoGAM, is what prevents that from happening. It gives mom some of those antibodies, the immune globulin, to keep from fighting off that baby. Okay, I hope that was a little bit more clear. If not, we'll discuss it again in class. But anytime there's a possibility that baby's blood could have mixed with mom's blood, so if there was a car accident and there's a chance that when the seatbelt went across that uterus, some bleeding may have occurred from that placenta, then I need to go ahead and get a RhoGAM shot, all right? Because anytime that blood mixes, then I'm more of an increased risk of having that immune response against the baby. So we really have to watch for things like that. So typically you're going to get that RhoGAM about within 72 hours after birth. And then we do that at 28 weeks, just to hopefully ensure that we're going to have a safe pregnancy. Okay. Um, yeah. Okay. So talking about RhoGAM again, that's the medication that we give to our negative moms. It is more to help not necessarily with that first pregnancy, because my body has to kind of build up that immune response to baby, but it is more for the pregnancies that come after. Okay, so we do give mom RhoGAM even if she has a miscarriage. So anytime mom delivers that baby, if mom is an Rh negative person, she's going to get RhoGAM. Okay. Um, it's never ever given to the infant or the dad because that's not going to help us, right? It's for mother. It's always given IM. It is considered a blood product. It is a derivative of blood, is where they get the RhoGAM from. So you have to get it from the blood bank, and it must be checked by 2 nurses. You return the syringe back to the lab with the label and everything intact, and they record that there. If mom has for some reason had a RhoGAM shot in pregnancy, they should actually have a little card. They'll give them a card that says, I had RhoGAM, this is the number, and this is the date when I had it. Okay. Um, so RhoGAM will try to destroy any of those fetal red blood cells that may have entered mom's circulation before mom can build up those antibodies to fight against it. Okay. Um, the majority of the population in the United States is Rh positive. We have most of our a good bit of our population is O positive. Um, so we, if this isn't a all the patients kind of thing, we're just talking about any mom that is a negative Rh factor. Okay, postpartum blues or baby blues. Okay. Um, This occurs in those first few postpartum weeks, should only last for a few days. Mom may be very tearful and cries very easily, but she should still be able to take care of herself and her baby. Um, so what happens? Why is this? Well, I go from having the baby on the inside, those hormones, and now I have either pushed or the baby's been delivered C-section wise. That placenta is out, so now the hormone levels are all wacky, right? Nothing is normal. Your body feels crazy, and that is typically a normal thing. Mom's very tired. I'm breastfeeding, so I'm awake every 2 hours. Every time I just get to sleep good, baby wakes up and wants to eat again. So fatigue can cause this as well. Stress from being a new mother, or maybe this is my second or third child, but the other kids are very young as well. So having to try to learn to juggle all this. So some of the things that you may see are anger, anxiety, mood swings, sadness, weeping, difficulty sleeping or eating. Now, if this is lasting longer than a few days, then we're moving towards postpartum depression. Um, Postpartum depression is going to be where there's a mom that cannot take care of the baby at all. Maybe I can't even get myself out of the bed to do it. I can't get up to take care of myself. Um, then there is a possibility that moms could move into postpartum psychosis, which is where you will see um, people that are really struggling with um, taking care of their children. Now I am in a psychotic, I'm having a psychotic break of some sort. Um, you may see these as women that kill all their children because they're, whoever told them to do it. If you, some of you will remember Andrea Yates, she drowned all of her children. There were quite a few of them. There were 5 or 6, I do believe. That's postpartum psychosis. Okay, so sometimes these ladies don't return from postpartum psychosis. They can not actually function and end up having to be in a mental care facility for the rest of their lives because of this mental postpartum psychosis. So we want to make sure that we catch moms kind of on the early side. So typically what I would say is um, moms, if they came in with a long birth plan, this is what they wanted to happen. They wanted, you know, no medication, and they just wanted to be off the monitor as much as possible. It never failed that these were the people that would end up with an emergency C-section and having every intervention you can think of. Okay, so that right there is um, a risk for postpartum depression. And women who've already, maybe have some depression issues beforehand, you go through this enormous, important delivery that has now changed from what you thought was going to happen, what you saw on TV and what really happens are totally different. And now I'm very depressed, and I have to basically have to grieve the delivery process, what I had built up in my mind. So, what I caution moms, especially if I see them prior to delivery, I say just be careful when you're doing a birth plan. Now, as a labor nurse, I will tell you that almost every person I've had that came with a very detailed birth plan ended up with a C-section. I don't know why, but that's the way it ended up. Okay. Um, Nurses in general are we are very sensitive to coincidences. There's another word I'm looking for, but I can't think of it right this second. Um, we're very superstitious. That's what I was trying to think of. So in my normal life, I am not a superstitious person, right? I don't believe in that. But when it comes to nursing, holy cow, I'm very superstitious when it comes to nursing. So you come in with a birth plan, and I go ahead and pull out your C-section papers, get them stickered, and put them in the front of the chart because it's just, that's the way it happens sometimes, most of the time. Okay. So someone who comes in with that extensive of a birth plan ends up with lots of interventions. They have to grieve what they thought they were coming to do. Okay. And so sometimes that takes over, and they're not able to move from the baby blues, and now I'm into a depression state. So we've really got to get a hold of that and stop that while we can. So anybody that has had a traumatic birth, had something emergent happen, anything that's out of the normal, I always take some time as a nurse to speak with my significant other and just let them be aware that this might happen. And if you start seeing that mom is not recovering well, that it just lasted a few days and now it's weeks, they really need to get with the postpartum provider because mom may have to go on some medication to help with that until we can move forward out of that kind of a depression state. So very real thing. Sorry, I'm very sensitive to postpartum depression and baby blues. So I do like to discuss it and, a good bit.